Bryn Whitney, Branch Manager and Vice President at Bangor Savings Bank. Bangor Savings Bank has been supporting our local communities for over 172 years, and we are proud to partner with MaineHealth Lincoln Hospital for this 5-part series on coastal medicine in Lincoln County. Bangor Savings is proud to work with Lincoln County Television and MaineHealth at Lincoln Hospital. We hope you enjoy this 5-part series as much as we've enjoyed supporting it. Thank you and enjoy.
My name is Reverend Oliver. I am the Director of Philanthropy here at Lincoln Health. I'm so pleased to welcome all of you here today. Really excited for this. This is our second Doc Talk. We had one in Booth Bay a couple of weeks ago, which was very well received. That was also televised, it was also filmed by Lincoln County Television, so you'll be able to watch that one as well. That featured our own Jeff Slack, who works right here in this building, and Dr. Rob Hummels. They were talking about palliative care, hospice, and how to afford the care that you need. So it's a really, really good one. If you missed that one, you'll be able to watch it. First of all, I would like to thank Bangor Savings. They have supported both of these Doc Talks, and we're so grateful for them taking a chance on us. This is something new that we're doing here, and really excited to have their support. So thank you, and Bryn and Julie are here to represent. If anyone would like to speak to them, please do. I also would like to thank LCTV. What a great supporter they have become of ours. They are working with us now to televise our community meetings, these Doc Talks. We're going to be doing some other events later on in the summer, so stay tuned. We're going to do some cooking events over at Rising Tide. That should be a lot of fun. Those won't be televised, but hope you can get into it. It'll be a free event as well. All right. So we also have some more Doc Talks that are planned later this summer. We're going to be doing one on carpal tunnel. And then our own Jess Pinkham will be doing a special just on the OR and what is happening there. Jess is going to be basically hosting our event today, and she is going to tell you some of the incredible things that we're doing over here, right here locally. So I would like to take a moment here and introduce Jess Pinkham. She is our Director of Surgical Services at Lincoln Health. Jess has been highly involved with getting a number of new surgeons here to Damascotta, and we're so grateful to have her here. So without further ado, Jess Pinkham, everyone.
Thank you, Revan, and all of you for coming today to learn more about Lincoln Health Surgical Services Department. Lincoln Health has 3 operating rooms and 1 procedure room. As a surgical services team, we are constantly looking to provide services that meet community needs. Last September, after a year-long recruitment process, we hired Dr. Ross Feller, a fellowshipped hand surgeon, and his brother Reed Feller, an ophthalmologist. These new surgical services addition has definitely increased our surgical volume at Lincoln Health. Bringing in the newest technology is something that is important to me as healthcare is continuously changing. In 23, Lincoln Health became the first in the state to introduce the Ingenuity Heads-Up technology, which Dr. Reed Feller will show you in just a few moments. Lincoln Health in 23 first introduced artificial intelligence with GI Genius. We were the first in the state of Maine to introduce this technology as well. GI Genius AI endoscopy module allows providers to perform 99.7% sensitivity in identifying colorectal polyps which may be precancerous. This demonstrates Lincoln Health's commitment to reducing colorectal cancer and increasing the survival rate with those diagnosed with colon cancer. As we continue to grow, Lincoln Health will be committed to working together so our communities are the healthiest in America. Without further ado, I introduce you to Dr. Reed Feller.
But thanks everybody for coming. Good morning. My name is Reed Feller. I'm excited about the opportunity to share what we do in the operating room. But want to give my thanks to the team here at Lincoln Health. So in particular, Jess for organizing this. But in if you're a patient with us in the ophthalmology clinic and in the ORs, you'll know that it's truly a team effort. So while I'm, executing the surgery while it's happening, there's a huge collective team effort involved to get patients to the OR, preoperative testing, mapping and planning surgery, which is a big part of cataract surgery. And then, what we do in the OR, getting patients prepped for surgery. You'll see it's just a huge coordinated effort, team effort. So, while I am the surgeon doing it, it's I couldn't do it with everybody else. So, with that said, we can go into sort of, I'm just going to narrate through the things we do in the operating room on the day of surgery, as this is called demystifying the OR. So right now, basically, we're having a discussion. To the left is our anesthesiologist, to the right is me, and we're just talking about any questions the patient may have on the day of surgery. We're going to prep this patient with some antiseptic solution in the eye, anesthetic, and dilating drops, because we, during surgery, rely on a dilated pupil for best visualization during surgery. And so this is our nursing team, basically, again, delivering drops, answering any questions the patient may have, keeping the patient comfortable. And obviously, we're preparing for eye surgery, and that's can be quite anxiety provoking. So again, not just me, but the whole staff is sensitive to that fact, and try, kind of some verbal anesthesia as well. Yeah. And so here we're in the operating room, and obviously we want to keep everything sterile to avoid any risk of infection. This is our scrub tech, Emily, and she's getting scrubbed in. Well, she is scrubbed in, but she's getting her gown on, and she's going to get all the instrumentation ready. She's going to glove up and get everything we need to have a successful surgery. Obviously, as with anything in life, preparation is really important. So what's the old quote? Preparation is the key to excellence and execution. So that's what we're doing here. While we kind of wait and go through this, this is all just kind of, everything is very programmed and routinized. And if you think about it like flying a plane, for example, there's checklists and safety checklists, and that's really important with any surgery. So basically, everything we try to keep as consistent and programmed as possible to avoid error. And so that's what's going on here. But while we're going through all of this, I understand that my brother is going to be coming as well. So he's a master hand surgeon. He's going to be going through carpal tunnel, but it's important, I think for the whole community to understand that people like my brother and myself and others are here to meet the demands of an aging community that's relatively underserved. So, there's not a whole ton of doctors and specialists around, and so all of us, I know there's an ENT coming, so all of us are here to, meet the demands of the community. So obviously, this is all preparatory steps. We could probably skip through a little bit and kind of get to the surgery. Yeah, and so here again, I'm kind of like sounding like a broken record. This is a safety check where we confirm the patient's identity, date of birth, what we're doing, what side we're doing. So any, hand surgery, eye surgery, anytime there's a side, we need to confirm the side and make sure we're all doing that safely. And so one important part of this is that, in my hands, you'll see that we have a box of lens implants. So during cataract surgery, we take your cataract out and replace it with a lens. And there's a lot of different lens options available to patients. We need to be sure that we have the appropriate lens size, power, type, etc. We can skip through.
Positioning.
We're just positioning the patient here. Again, there's a lot of preparation that goes into this, so we'll get to the surgery in a moment, but just kind of emphasizing the fact that we get patients ready, we get them comfortable, appropriately positioned. You'll see we have an operating microscope in the back, and then we have a monitor. So that's a kind of a special thing we do here. Actually, we're the only place in the state that does this, that's adopted this technology, but it's called heads-up. It's a heads-up operating microscope. So traditionally, as eye surgeons, microsurgeons, we look through oculars on a microscope, and basically the microscope is positioned over the patient's eye, and we look through the oculars to visualize what we're doing. Here in our operating room, it's a 3D visualization system where we basically have the microscope over the patient, but we're looking at a monitor. So we're not constrained to oculars. Our posture is maintained. Ergonomics are maintained better. It helps with our longevity. And then the technology, we can sort of adopt new technologies as they come. So this new 3D visualization, we can superimpose alignment, digital alignment to align toric intraocular lenses, for example. So those lenses correct for astigmatism. This can be synced up to a cloud-based situation where we can have all our safety checks performed on the monitor. So instead of relying on paper and things like that, we can do a surgical timeout that way. Now we're just cleaning the eye. Again, it's about safety. So that's certainly the most important thing in surgery, is performing it safely, effectively, and efficiently. Okay, we're draping the patient. Patient's been cleaned, prepped, covered. Now we're going to get started. I'm just getting positioned now, getting the microscope set up. We have our Mayo stand, so a tray with all the instrumentation we'll need. So we, again, keeping everything clean, positioned. I put a eyelid opener in to keep the eye open during surgery, and we squirt the eye with sterile solution to keep it moist and lubricated during surgery. Yep, so we're in surgery now. So lights are off. I am visualizing the eye. You see it in the background there. I'm filling the eye right now with a gel, a kind of a viscous substance to keep the eye inflated and protect the cornea during surgery. So that's what we're doing here. Now I stabilize the eye. So I have an incision made on the left side, and now I make a main incision that's a little bit bigger through the cornea, again, the clear covering over the pupil. And we make our incision here. And that's a good incision. After that, we start to access the cataract. So the cataract is suspended in a capsule. That's a very thin, microns thick structure. But basically, right now I'm peeling the capsule centrally to make a circular opening. That allows me to access the cataract, which is basically, the substance that we're trying to remove from that capsule. So right now, just being very methodical, and keeping the eye, the opening we're making centered, and we're almost done. And after that, we're going to get to dealing with the cataract. So right now, it's just being able to access the cataract. So a nice circular opening here, and that is complete. So now we're dissecting a plane in the eye. So that, as you can imagine, the cataract is somewhat adherent to the capsule we just dealt with, but we need to make basically a fluid dissection wave, which is basically what we're doing here. So we are using that cannula, which is attached to a syringe filled with sterile solution, and we're making a fluid dissection wave all through circumferentially around the cataract. So that's been done here. We can continue now. Now we have a very special machine. So we have two instruments in the eye. On the left is just what's called a chopper, which is just a mechanical instrument that I use to give me leverage to break the cataract up. But more importantly, the instrument on the right side that's gone through our main incision port is called the phacoemulsification probe. And so a phacoemulsification machine is not in our screen here, but it's off to the side, and it basically is very advanced technology that allows us to deliver ultrasonic energy to the substance of the cataract, create a trench and to remove the central core of the cataract and then break it up by basically delivering ultrasonic energy and using mechanical forces to break it up. Now we are vacuuming out pieces of the cataract. So we break it up and then we basically vacuum it out of the eye, essentially. Okay, so that's what we do to deal with the vast majority of the cataract material. So break it up, vacuum it out of the eye. Now we're left with some residual lens material that's kind of adherent to the capsule, and that's called cortical material. So what we removed before was nuclear material, which is more dense. This is more kind of friable and sticky, and so we use a different probe, and we kind of work circumferentially around the periphery of this capsule, and we remove the cortical material like so. So we're just taking our time, being gentle, and removing all this material. It's clear inferiorly now, so there's no more left, but we're working on superiorly the remaining cortical material. So that's going really well. Now we have a nice clean capsular bag, so everything has been removed. It's, as you can see, much more clean. There's a nice central opening that we made before, and now we're going to implant our lens. So with some gentle pressure, we get this lens in, and then we deliver the lens implant into the space we have made by cleaning out the cataract from its place in the capsular bag. So gently, again, implanting this lens, and then we're going to put it in its proper position. So our lens is in now, and now, as we alluded to before, the eye was injected with this gel, sort of viscous substance. So that's done at the beginning of the case and at the end of the case. And the point of that, again, is to keep things inflated and protect the cornea, but also to safely deliver the lens implant. So this is our lens implant behind that probe there, and that's good for the rest of your life, and it'll deliver really good vision. But essentially, right now, we're just removing that gel-like substance from the eye, and after that, we are going to move on. This patient not only had cataract surgery, but also had a glaucoma intervention. So glaucoma is a pressure-sensitive problem with the optic nerve. So the way we deal with glaucoma uniformly, whatever type of glaucoma or severity of glaucoma, we need to lower the eye pressure in some fashion. So in this case, we did a combined cataract surgery with a glaucoma surgery where we put a stent in a particular part of the eye that drains fluid. So if you think about it like plumbing, you can either lower pressure by decreasing the production of fluid in a space or by increasing outflow. So in this case, we increase outflow by stenting a particular part of the eye. So we can move on to the glaucoma case. So this is our cataract surgery. So to summarize it, we make incisions in the front of the eye. We access the cataract by making an opening in its capsule. We then apply ultrasonic energy to the cataract to break it up into pieces. We then vacuum it out of the eye, the nuclear pieces that are denser. We then clean up the capsule it was in, all the remnant sticky cortical material. We then fill up that capsular bag and place a lens implant in the eye. After that, we remove the viscous substance we've injected in the eye a couple times during the case, and the incisions are sealed with sterile solution. So we just hydrate the incisions typically. Sometimes they need a suture, but that's very rare.
What's the duration of the operation?
Operation depending on complexity. So cataract surgery, while it's kind of the same ultimate goal, can be of varying complexity. Routine cataract surgery, sometimes I can get in and out of the eye in 10 minutes. I think usually 15 minutes if it's more complex. So I'm looking at I have a patient in this audience who had a more complex surgery with me. That took about 30 to 45 minutes. So it's quick surgery.
When you do the stents,
It increases the time probably by about, 5 to 10 minutes. 10 minutes, 5 to 10 minutes.
Thank you.
Yeah.
Could I take you back to a basic
Sure.
question? What causes a cataract to develop, and what is actually the makeup of it? What kind of material is it?
It's proteinaceous material, and it's just aging. So it's a normal aging process. Sometimes it can be related to, like, for example, poorly controlled diabetes or trauma, some extenuating circumstances like that. But uniformly, it's just aging, oxidative damage, and it makes the lens proteins change and become less clear. So right now we're doing the glaucoma portion of the surgery. So we have a special lens on the eye, and we're visualizing the angle of the eye. So that's the structure that is between, like, basically your cornea and your iris kind of form an angle, and in that space there's a drainage structure called the trabecular meshwork. That's important for the outflow of fluid from the eye. And so we're putting stents in, these tiny, tiny little stents. You see a little blood there. That's a sign that we're in the right spot. That's going to be effective. So again, it's a tough view for y'all, but basically we are stenting the trabecular meshwork, and you can see that little metal with a little bleeding from it, and that's called the trabecular microbypass stent, and that is aimed at lowering the eye pressure.
Just put one of those in?
We put 3. So yeah, that's an example of one. So okay, and we can move on now.
What's the success rate of that?
It's a little, I think it depends on who's, the hands that are working with it, but I think that they're pretty successful. I mean, it's not, like a 50% type thing. I'd say in general, it's much.
In terms of delaying glaucoma?
Well, it's not delaying, it's treating glaucoma. So you're trying to lower eye pressure. So usually you get, a few points reduction in pressure, and hopefully you can kind of reduce drop burden as well by doing these stents. Yeah.
Question, is there any way that you can calibrate what kind of pressure drop that you're going to anticipate?
It's a good question. So these are aimed at kind of mild to moderate glaucoma. Anybody who needs, dramatic pressure lowering, these stents aren't going to deliver that. So they're certainly going to deliver a several drop, typically several points drop in intraocular pressure, hopefully reduce topical drop burden. But there's kind of a spectrum of interventions with glaucoma. There's much more aggressive, more morbid procedures that can be done and sometimes have to be done, but this is a more conservative and safe approach that has less complications, and it's less morbid. So it's a kind of a class of surgery called minimally invasive glaucoma surgery that's kind of picking up steam in what we do.
You also do a lot of in-the-office procedures.
Yeah, so I guess that concludes our presentation of surgical videos. So we kind of touched on cataract surgery and some glaucoma surgery that we do here. We're exploring other minimally invasive glaucoma surgeries to offer in the OR. But in addition to these intraocular surgeries, I do some eyelid surgery, so malpositions of the eyelid, so droopy eyelid turning out, eyelid cancers, things like that. And then in the office, I'm sure a lot of you have friends that are on intravitreal injections, so injections for macular degeneration or diabetic retinopathy. My partner and I do a lot of that as well in the office, and that's something that I think we're going to have to do a lot of because of our aging population. So let's listen to a few of the patient testimonials. So we had some very gracious patients come and talk about their surgery, and we'll listen to those now. Thank you.
Good morning. My name is Joel Russ. I live in Walpole, Maine, and I've recently had cataract surgery on both my eyes at MaineHealth, and ophthalmologist Reed Feller and his team. It was a remarkable experience for me. It was needed. I didn't hesitate to say yes to the suggestion that I have the operation, and it couldn't have gone better. From the very beginning, when they assessed my need, to the prep, to the operation itself, which I don't remember that much, I was heavily sedated, until post-operation services and advice and medications, which were minimal, but medications. That was over a month ago. My vision has improved substantially. I still need corrective lenses for nearsightedness, but I've had glasses since I was in the 2nd grade, and for the first time, I have not had to wear glasses driving. So it was very successful. My hat's off to MaineHealth and their ophthalmology team, and also to this collaboration between MaineHealth and Lincoln County TV. I understand it might be the beginning of a series on understanding or taking the mystery out of operations, and I commend both institutions for making that possible. I guess I was a guinea pig in a way, and I don't mind doing that at all. I said to Larry earlier today that he knows more about my operation, he and this cameraman, Haven, know more about my operation than I do. So I'm happy to share this story with you.
Hi, my name is Sharon Sperry. I'm from Newcastle, Maine, and I recently had the amazing experience of having both my cataracts done about 2 weeks before with Dr. Reed Feller and his team, and I have nothing but positive things to say. First of all, beginning with the prep that was about a month or so earlier, right up to the follow-up visits. Everything was smooth, it was well prepared. I was well prepared for the experience. I was terrified originally because my dad had success with one eye. He did not have success with the second eye. Dr. Feller knew that I was very nervous, and he did not physically hold my hand the entire way, but emotionally held my hand the entire way. I've worn glasses since the 4th grade. I woke up after the first one was done and could see the little clock on the TV in my bedroom. And it was the first time I'd ever woken up in the morning and could see. And it has gotten progressively better. Now, I do wear readers, actually cheaters from Rennie's for reading, but he set my eyes up so that on my iPad, I can play bridge without glasses. So my thanks to the extraordinary professionalism of Dr. Reed Feller and his team at Lincoln Health. And I just celebrated my 75th birthday, so if you're approaching your 70s and someone tells you to get cataract surgery, don't hesitate. Thank you.
Thanks.
Have you used the new J&J Clearview lens, I think it's called?
I'm not familiar with that. We use J&J lenses quite frequently, so the lens that you saw there is a J&J lens, monofocal lens. We are using, multifocal and extended depth of focus lenses. That requires a lot of, we have to be careful of who we put those lenses in, but it's certainly appropriate for folks who are committed to not needing really not wanting to wear glasses. But that's a conversation, kind of an extended conversation to have on an individual basis.
What about astigmatism? I see you have to rotate the lens. I just can't imagine how you can know.
So we do a lot of toric lenses, and there's a technique to doing that and aligning the lens, and that's an advantage of what we're using with our heads-up microscope. Is we're able to have like a digital overlay of where the lens needs to be aligned. So we use that as guidance.
And that would be a lot better than just remembering which, 1 o'clock or 2 o'clock or whatever.
Yeah, there's different ways to do it. A lot of it's like hand marking, and we make a little hand mark when we do it, but we use a digital overlay to align our lenses. So it's one strategy to be more precise about that.
Thanks.
Yeah.
If you're doing 2 eyes, what kind of time period between the 2 eyes, or can you do them both at the same time?
You can do it both at the same time. It's a testament to how safe cataract surgery is. I haven't adopted that yet, and most surgeons haven't. But I could see that coming down the road, eventually, that there's talk of that. But for now, we're doing, and that'll be the case for a while, is 1 eye at a time, a week to a few weeks apart. So, yeah.
I think it's more practical anyway, despite capabilities, because you got to put a plastic patch on the eye to cover it. It's it's clear, but you're all taped up across part of your field of vision too.
Yeah.
And you just had an eye worked on. It takes about 24 hours to come back to regular vision, but you're still looking through this foggy plastic. I wouldn't have wanted to have both of them on the same day.
No, yeah, I think I don't know, a lot of surgeons are exploring that and are interested in that, and I'm not saying it's wrong. That might be what we ultimately do. I mean, everything will be evidence-based, whatever choices or changes we make. But for now, our practice is to do 1 eye at a time.
With the necessity to cover the eyes, though.
Yeah, no, agree. Yep.
Why would anybody want to do both? Get it over with.
Thanks.
Are there conditions that preclude cataract surgery?
It kind of gets into the area of like complex cataract surgery. So Virginia had two complicated, surgeries that, some folks didn't think it was wise to do, and that's a judgment call. I think. So what was the question? Contraindications? Sure. Yeah. They're all any surgery will have situations where it's not wise to do it. Whether there's risk to kind of irreversible vision loss or something like that. But we're kind of talking about very specific circumstances there. Yeah.
If one has had a detached retina
Mm-hmm.
in the eye, where there's how does that add complication? I would assume.
Yeah, it adds a little wrinkles to the technique and stuff, but we do them all the time. I mean, people who've had vitrectomies, there's certain things you do intraoperatively to deal with that. But yeah, we do it routinely.
Well, thank you everyone for coming.
Thank you.
Thank you. This was fascinating.
Oh,
Yes.
good.
Yep, it really was. Thank you.
Yep.
Thank you.
Yeah, thanks. Thanks, everybody.
I hope it helped.
Okay.
Hager Enterprises, a paving and excavation contractor specializing in all sorts of site work, utility installations, and road construction since 1987.
When Tidewater Telecom built Lincoln County's first fiber-to-the-home network in 2011, we knew we were starting a project that would take years to see through. 9 years later, we are proud to have connected more than 2,000 Lincoln County homes to our blazing fast open fiber network. But that hasn't dimmed our vision to connect all of Lincoln County.
Learn more about the power of fiber optic internet at tidewater.net.